Good evening, everyone. Welcome to our webinar on hip replacement surgery. My name is Anya, and I'll be your host this evening. Our expert presenter is consultant orthopaedic surgeon, Mr. William Dunnet. This presentation will be followed by a question and answer session. If you'd like to ask a question during or after the presentation, please do so by using the Q&A icon, which is on the bottom of your screen. This can be done with or without giving your name. Please note the session is being recorded if you do provide your name. If you would like to book your consultation, we'll provide contact details at the end of this session. I'll now hand over to Mr. Dunnet, and you'll hear from me again shortly.
Well, thank you very much for that. And welcome, everyone. Quite personally, I would say I can't think of any better place to be on a cold, windy, blustery night than being tucked up indoors in your own homes and discussing a topic that's close to my heart, which is orthopedic surgery in general and total hip replacement in particular. So here we go. First slide is going to be coming up fairly shortly, as long as we go from there to there. So that's me, William Dunnet. I'm one of the orthopedic partners that work here at Benenden, along with 7 others who are providing lower limb total hip replacement. What I'm going to include in this session is a little covering of my own experience, and then I'm going to discuss Benenden Hospital and where we stand in the pecking order of the private hospitals in and around Kent and Sussex. I'll cover our 8 orthopaedic consultants and discuss a little bit about them and discuss the unit volumes that we're doing of total hip replacements per year. And then I'd like to discuss a little bit about hip arthritis, because I believe to ensure people get a good result from hip replacement, they need to have a working understanding of the process of arthritis and understand how hip replacement is going to help patients in overcoming the arthritic symptoms. So we will discuss that in a moderate amount of detail. And then we'll go into the operation itself. There's loads of stuff on YouTube, and you can watch hip replacements. A lot of it is quite gory and not particularly pleasant. I am going to show you the important things from my point of view without any ghastly photographs that put you off your supper. So you don't need to worry about that. And then we're going to finish up with some patient support tools. All that means is just giving you a little bit of guidance as to where you can get more information online. And then finally, there's going to be a question and answer session. Now, what I'd say about that is that these presentations can be quite dull and rather lifeless if I just rabbit on about various things I'm interested in. And the thing that really brings it to life and adds color and enthusiasm to everything we're doing and makes this a more engaging process is if you can come up with a few questions at the end that I can try to expand on for you. And it also helps me because every time I do one of these presentations, I like to make it a little bit different, a little bit more varied. And even though the slides aren't changed too much, I make a point of not rehearsing it too much in advance so I can maintain some spontaneity for you. But particularly if you give me some good questions, I can then change the presentation next time to align it better to what you really want to hear from me. So on we go. That's me, William Dunnet. I did my preclinical training at Cambridge and then moved down to Guy's to complete my medical training at Guy's Hospital for 3 years. I'm interested in both hip and knee surgery, and I developed these interests at the Royal National Orthopaedic Hospital when I was training as a registrar and also at King's College in London. I spent just over a year in Australia where I worked with some absolutely incredible surgeons. And the reason most of us try to have engaging fellowships like this is because there aren't many people who are brilliant surgeons, but if you can just work with them for a while, you can see what surgeons can do when they're at the top of the game. Most of us are average, but what I like to think is that as a surgeon, if I occasionally sit on the shoulders of brilliant surgeons, I can at least do something to emulate the quality of their practice. So that year I spent in Australia was really quite a good year for me in many ways, and that has influenced my practice over decades afterwards. And as a result of that interest I had in Australia, I was the first surgeon to introduce a certain form of keyhole surgery that allows you to reconstruct the anterior cruciate ligament of the knee in a quick, effective way that allows everyone to return to their quality of living, their sports, whatever it is they may be, in a quicker, more effective way. So that's what I learned from some of these great surgeons I worked with as a registrar. And I belong to the Royal College of Surgeons, the British Orthopaedic Association, British Association of Surgery for the Knee, and the General Medical Council. So what about Benenden? Well, it's in our nature to be fairly modest, I would guess, but I don't think we need any modesty about saying that we are, in fact, a leading provider of private hip and knee treatments in Kent and Sussex. We were actually pipped to the post by the Horder Centre in the number of cases we do per year, but we're pretty much up there in the top leading hospitals within this area of Kent and Sussex. Now, here is me saying that the treatment is in a clean and calm environment. I think it's quite important that I expand on this a little. Most of us are primarily NHS surgeons. We spend 70 to 80% of our time working in the NHS. And mostly because of COVID, but because of other reasons as well, the NHS is a fraught, difficult environment to work in, but nonetheless extremely satisfying. But all of us would be exhausted and worn out and burnt out if we didn't have places like Benenden to come to. Here, we don't have an emergency department. Everything is done electively. And when you come into the hospital, you come through the incredible great atrium that was developed a few years ago, and you realize that this is a very special hospital. There is a calm atmosphere here. It is tranquil, and the staff are happy. They're engaging. They are supportive and very caring. And that happens because of the whole ethos of Benenden. And the staff churn rate here is in fact very low, because once people start working here, they want to stay here. And that whole ethos that we have here will be transmitted to you, the patient, because if you enjoy your time here, when you come to have your hip replacement surgery, you will have a quicker, better recovery when you return home. There's an experienced team of orthopedic consultants and physiotherapists. I shamefacedly say that we are quite careful in selecting surgeons who are going to work in our consortium. We don't tend to have relatively junior consultants. We tend to invite people to join us who already have an established private practice, who are quite experienced, because we find it just gels together better and the service works extremely well. So we are quite experienced surgeons that'll be working here. Some of us having more grey hair than others, I'm afraid, but that's not a bad thing. We're not old and past it yet, but we certainly are very experienced. There is a high patient satisfaction rate. Like everything nowadays, you actually must listen to your patients first and foremost. And we sort of, okay, it's a bit boring when you're given compliments. It's actually the things where you're criticized for that we learn the most. And I think over the years, we've managed to really build up our reputation enormously by being very self-aware and self-critical and improving where is necessary. And as a result of this, we now have extremely high patient satisfaction rates when they have their treatment here at Benenden. Now, this thing at the bottom, the Rapid Recovery Program, that is something that's quite an interesting concept. It was first developed quite a few decades ago now in its infancy, when we recognized that healthcare is expensive and becoming increasingly so. And one of the most valuable resources is time spent in hospital. So both in the States and here in the UK, we were trying to find ways of speeding up the patient recovery process. And the most extraordinary thing we discovered is that, okay, the reason we were trying to have rapid recovery was to get people out of hospital quickly so that operations wouldn't be so expensive. But what we realized is, paradoxically, if you get people home quicker, they recover quicker and better, and they have less pain. And of course, when you begin to analyze it, you realize the best place for people to recover from surgery is in their home environment, where they have all their creature comforts, they have their own cooking, they have their own bedroom, their bathroom, and all that kind of stuff. So we've recognized now, if you can get someone home, often after only one night's stay in hospital, they thrive and do better. But of course, we don't push people out of hospital too early. We make sure they have good pain relief. We make sure they've had adequate physiotherapy, and they feel confident to return home. But this rapid recovery program is something that we've really developed and adhered to over the last few years, and it's just led to incredible results. It really has. So what about the consultants? Well, here are our mugshots. There are 6 of us who are now providing hip replacement surgery. A few of us also provide knee replacement surgery along with some of my other consultant colleagues. And I would say the one thing that describes us is we are a partnership of colleagues. We rely on each other for support. We discuss difficult cases with them. And at weekends, we'll often cover ward rounds and cover seeing our patients if perhaps you're going on a holiday or whatever. And we'll do that with ease and with no problem at all, because we are not what you might see in certain other hospitals, downright competitors of each other. We are supporters and partners, and we have a great sort of camaraderie between us. So that adds to us loving coming here, because it is a calm, great environment, so we can actually enjoy what we love doing, which is our practice of orthopedics. And I'd be quite happy for any of those consultants to operate on my hip. So here we are. Here's the number game. The Horder Centre have just pipped us to the winning post, I'm afraid, with 300, but 290 private hip replacements last year is still extremely good. We are a very successful unit, and we are proud of it. So here we go, the causes of hip arthritis. So before I go down that slide, I can tell you the commonest cause is idiopathic. We don't know the cause, but it just tends to run in the family, run in the genes. So as many great attributes as you might have got from your parents and grandparents, I'm afraid to say they're probably, if you have got arthritis, they're responsible for you getting your arthritic hips and knees as well, I'm afraid. But there are also other causes. The general aging process does lead to a little bit of wear and tear in the joint, but that is not usually sufficient to need a hip replacement. It just gives you a little bit of achiness in the morning. That's what we call startup pain. It settles after a few minutes, and it can make your joints a bit stiff in the cold weather. But that's nothing to worry about. That's just the fact that you're getting on a bit in years. So we don't worry about that. What you do notice, though, is that arthritis does tend to be a little bit more common in females. Well, actually, probably the reason that we have this statistical anomaly is because women live longer than men, so they are more likely to present with arthritis. Obesity, now that is a real thorny topic, and one must be extremely careful about that. It's very commonplace to tell people, well, you're overweight, so you're wearing out your joints prematurely, lose weight, and they might get better. That's true to a certain extent, but not really. And what do we regard as obesity? If your BMI is a little high, but below, shall we say, 35, so in other words, you look a little portly, a little plump, quite frankly, it is not associated with increased risk of arthritis, or the symptoms being significantly worse than they would be if you weren't overweight. So I try not to be fattest in my approach, because I think it's appalling, you know, and we're a wonderful sort of, humanity is a huge variety of people, and you take them in all shapes and sizes. If you are significantly overweight, and I mean really rotund, then of course it increases the pain you get from your joints, and also it makes the risk of surgery higher. But that is only with severely elevated obesity. So I don't like to mention that as being a cause of arthritis, because by and large, it isn't. And we have to be a little bit more sympathetic and generous in our approach to people. Joint injury, well, yes, that definitely does, I'm afraid to say, cause arthritis. If you fracture a joint and a smooth joint then becomes unsmooth, disjointed with a rough bit of bone sticking into it, you will inevitably get premature arthritis because of the abrasive effect of the uneven surface area. And finally, rheumatoid arthritis and gout are associated with an increased risk of arthritis in the joints. So what about the symptoms? Well, quite often patients think that they've got a groin strain, or they think they've got pain in their knee, or they just notice it's difficult to do up their shoelaces or do their pedicure, because they're getting a variety of problems that are related to a hip, but actually not obviously coming from the hip. So it's our job as an orthopedic surgeon to just listen to a patient's history and try to work out from that the kinds of symptoms that might be coming from an arthritic hip. And this is often why the presentation is delayed, because the patient doesn't recognize, and nor does the GP or the physiotherapist, that actually this patient is suffering from an arthritic hip. So the joint tenderness is more likely to present for someone who has an arthritic knee, because a knee is more superficial than the hip. A hip is well concealed within muscle. And so it's fairly rare that you'll be able to really palpate and feel the hip proper. It's more likely you'll feel a knee and recognize that's where you're getting the pain from. But here we are, the next line, increased pain and stiffness when you haven't moved your joints for a while. Now, there is a difference between the startup pain you get when you're getting well into middle age, when you wake up in the morning, you're a bit stiff, because that settles within a few minutes. But pain that persists for more than 20 minutes after you get up is more likely to be pain that's related to a form of arthritis. So it's not the pain per se, it's the duration of the pain and the time it takes for it to recover that indicates you might have an arthritic joint. Again, more likely with knees and ankles and wrists and things, you will see the joint looks a bit knobbly and deformed. So that's a sign that, yes, you're getting some arthritis there. Now, the next line is a grating or crackling sound or a sensation in your joints. That's something we call crepitus. I spend a lot of my time telling patients that actually what we call a musical joint isn't necessarily an arthritic joint. It can be due to a little bit of scarring of the fat pads in and around the joints. It might be due to a cartilage tear in the knee, or it might be due to a little bit of air in the joint that can create a cracking sensation in it. So it's not a disaster if you've got a cracking joint. It's something that, yes, it's an indication that maybe a doctor needs to look at it, but by and large, it's not related to significant arthritis. So don't worry about that either. The weakness and muscle wasting is often a guide to me when I examine patients that they've got a painful joint due to whatever reason it might be. It might be pain because of arthritis. It might be pain because of just disuse, because they've had a nasty ligament injury, or maybe they've been very unwell in bed for a while. But it's the cause of the pain that we've got to look at. And it might be arthritis, but if you have got a painful joint, you don't move it so much, and the muscles do tend to get weaker. And so the corollary of that is if you can then have physio and build up your muscles and strengthen them around your joint, then often the pain you get in the joint improves. And finally, a limited range of motion in your joints. I referred to it earlier that if you're finding difficulty with trimming your toenails and putting on your shoes, then there's a possibility that you've got an arthritic hip that's responsible for these problems. So treatment options. This is very important. And I mean, I am more than happy as a surgeon to see people with very early arthritis. Remember, I'm not a sort of ghastly, sort of crazy, mad surgeon who wants to get my knife out and cut into you and put a new joint in as soon as possible. It's quite the opposite. I have the perspective of what hip replacement can do for you, but also at the same time, I am delighted if I can delay or even avoid a hip replacement altogether and find simpler means of helping you overcome your arthritic symptoms. So what can we do? Lifestyle changes. Well, I saw a patient this afternoon who said, yeah, you know, I normally like to walk for 3 hours a day with my dog. And as a result of my arthritic hip, I now only walk an hour. And actually, I'm quite happy. It's taken away the pain, and that's good enough for me. That was his opening gambit, and he says, I'm not quite sure why I'm coming to see you. But then when I discussed a few more things in detail, I realized there are other aspects of his life he liked doing. And his wife that was with me also told me a few more details about things that they were no longer doing, or the fact that his walking had slowed up to such an extent when they went on holiday, she would have to carefully decide which sites they were going to look at, because she knew full well that her husband with his stick was going to be walking very slowly behind her. So I sort of drilled down a little bit, and I found that even though he thought he'd adapted his lifestyle sufficiently, his wife felt that he'd adapted his lifestyle too much, and they weren't enjoying some of the best years of their life together. So that took a little while for me to just disentangle what was important and what wasn't important. And I recommended for that particular patient that yes, he should go ahead with a hip replacement. But there are times when you can do lifestyle changes that will allow you to enjoy life, and you can avoid surgery, maybe permanently or at least for a year or two. What about pain relief medication? This is very important if you have you're going to go on a big shopping tour in London, you're going out to the theatre or whatever, you want to have your joint as good as possible, then some temporary pain relief is a good thing. If you're having to take strong painkillers all the time, that's not such a good thing because they can have side effects. So I much prefer that people don't let the arthritis get so bad that they need regular strong painkillers to try to take the edge off it. You're then getting close to the stage where maybe hip replacement will be in your best interest. But when it comes to the type of pain relief, we have a pyramid of analgesia. And right at the base of the pyramid, we like to think of medications that have very few side effects and are pretty efficacious for early symptoms. And that means the real sort of base building block is paracetamol. 2 tablets 4 times a day is not going to lead to any harm. It's not going to lead to any addiction or dependency, and it's unlikely to lead to any side effects. And you just add into that the occasional Brufen if you can take it, if you're not asthmatic and you don't have GI upsets and ulcers, then that's a lovely sort of base for your pain relief. As soon as you go high up the pyramid, every form of analgesia has its side effects, has its problems. So we try to play around with that to try to ensure that simple things with few side effects can be efficacious. So that is something that can help a lot of people with early arthritis. Steroid injections, you may have heard of. Yes, there is a role for them, but only very limited because they do carry risks. Steroids can damage bearing surface and can lead to infection. So you've always got to have a chat with your doctor and work out the risks and the advantages of steroid injection. But in the long-term management of arthritis, they do not play a role. In the short term, they can do. TENS. Now, what is that? Well, TENS is transcutaneous electrical nerve stimulation and hot and cold ice packs. What are they doing? Well, it's all to do with something called the Melzack and Wall gate theory of pain. Now, that's a very grandiose term, but I'll explain it very simply to you and quite effectively, I think. If you bang your head on a beam because you get up too quickly and you rub it, lo and behold, the pain goes away. That's because the painful stimulus of banging your head has been suppressed by the local pressure of rubbing. And you imagine pain fibers are different in the kind of perception they give your brain. And if you have this narrow little gate and you have one load of pain fibers providing a painful stimulus, and then you block that stimulus by lots of low-grade rubbing discomfort, there's nowhere near as bad as pain, it goes through the gate and blocks the gate to those pain fibers. That's what happens with hot packs, ice cold packs, and even transcutaneous nerve stimulation. You provide non-painful stimuli, but a lot of them that suppresses the painful stimulus. Most patients tend to put a wheat germ bag in the microwave and put it on their sore hip and their sore knee, and that helps. There's always a role for this to help you get to sleep at nighttime and use from time to time. But if you're having to use it all the time, again, it's more likely we're going to be looking for joint replacement. Using a stick and a cane, of course that helps, because what it does, it takes a lot of the load off the arthritic hip and makes it easier to walk. So that can help in the short to medium term. Special footwear and insoles, if you can reduce the impact loading on the joint by wearing a nice soft sole, sort of padders and hotters, they tend to have nice soft soles, that can alleviate some of the symptoms of early arthritis. And physiotherapy, my goodness, that can help a huge amount because it makes the joint more supple and flexible. And if you have a supple, flexible joint, it makes it easier to reach down to your feet. And it also takes the load off the back and the knee, because if the hip is stiff, the back of the knee has to move more to adapt to the stiffness. If you can make the hip more supple, then the back doesn't have to work so hard doing crazy contorted movements to adapt for the horrible stiff hip. So that's how physiotherapy can help. And the surgery that we're mentioning on the right-hand side, well, traditionally in orthopedics, we do 3 things for an arthritic joint. We either excise it, replace it, or we can fuse it. That's traditional orthopedics. Nowadays, we don't tend to do joint fusions of hips any longer because we've got this wonderful solution, which is hip replacement. Nor do we tend to excise the joint because that's very inefficient if you have a wobbly joint with no ball and socket there any longer. So hip replacement is the gold standard treatment for an arthritic hip. So here's our introduction to hip replacement surgery, a few facts and figures. 48% of hip procedures were done within independent hospitals in the UK in 2021. Now, this is a figure that makes my heart bleed. I'm very ashamed of this. You know, most of our surgeons here, we are NHS surgeons. We love the NHS. That's where we've been taught by great surgeons. That's our alma mater. That's where we've been brought up as in orthopedic surgery. And that's our role, you know, to provide a service to people that perhaps can't afford private insurance, can't afford to come to a private hospital. And to have to say that 48% of hip procedures occurred in the independent sector is extremely, extremely sad. But it's because of what COVID has left us with. You know, quite rightly, cancer has been treated well during COVID, and we've made sure that everyone's they've been adhering to their 2-week limits to get effective treatment starting. So hip replacements have fallen to the back of the queue. And in certain trusts, I was told by a patient today, there is a 3-year waiting list for hip replacement surgery. I mean, at least where I work in the NHS, it's about a year, but 3 years is just makes my heart bleed. It's horrendous. So, okay, the independent hospitals are working hard to provide hip replacements, and we've got great hospitals like Benenden that can do this. But I am very shamefaced when I have to say that's a state of play. And I really hope things are going to change for the better within the NHS in fairly short order. So over 84,000 primary hip replacements were performed in the UK in 2021. And so that means over 40,000 were done in the private sector. Hip replacement is the second best operation in the world behind cataracts. I must say, I thought coronary artery bypass graft was very high up in good operations because, of course, that saves lives and improves quality of life. But no, these are the figures. So that means hip replacement is not only extending people's lives, it is also improving the quality enormously. So you can enjoy some of the best years of your life by being essentially completely pain-free with a normal hip joint again. And some of the figures we've got here, well, the average age for having a hip replacement is in your late 60s. 60% are ladies, but that's mostly because they live longer, as I've said, compared to men. 5% of them are because of trauma, and 90% are because of osteoarthritis being the cause. And then the other 5% is various other things that lead to people needing a hip replacement. 28.7 is the BMI for the average person having a hip replacement. That is regarded as being overweight. But, you know, quite honestly, that's just normal, really, for the population as we are now. We're not perfect as human beings. We do tend to eat and drink too much. And so we are a little bit overweight. That is not the cause of the arthritis, and nor will it prevent you from having a great result from your hip replacement. So let's not be too concerned about being overweight. Next. So what is a hip replacement? Here's a remarkable thing. We are still not entirely sure where the pain generators are in an arthritic hip. You can see some people that have a colossally worn out hip and they just say, oh, it's a bit achy from time to time, a bit stiff. Other people have relatively minor arthritis on x-rays, but my goodness, they have disabling pain. So given we're not quite sure where the pain is coming from, it is remarkable that simply resurfacing the joint leads to such incredibly good results. But over the last 60 years, we have discovered that if you simply resurface the joint, you will get a great improvement in pain and you'll almost restore normal function to that joint. And all we're doing, as you can see in this slide here, is we are putting in a new socket. We are putting in some form of couple, which might be metal on plastic or ceramic on plastic, or even ceramic on ceramic as the joint. And then we put a stem down the femur that will secure it to the body's skeleton. Obviously, Andy Murray, who's, you know, we all sort of love and know well, really, from his sporting prowess, he's had problems with his hip, and he had something called a resurfacing. The point of a resurfacing, which is a very intuitive, nice solution for arthritis, which you do no more than resurface a socket and resurface a ball, but leave everything else intact, is that it leads to a very natural feeling joint that should be very robust and very stable, so it allows you to return to all manner of sports. And we used to do a lot of them, but we've now found there are certain problems with them, and the wear debris can lead to almost insoluble problems in a few patients. So because of that, we tend to go back to the more traditional design of having a long stem that goes down the femur and a more robust resurfacing of the socket or the acetabulum. So The question is, do you need a knee replacement, or do you need a hip replacement rather? Everyone is different, and you need to tailor the operation requirements to each individual patient. And we have 20 minutes that we'll spend with each patient that we see in clinic to really get a feeling of their life story, what's important for that patient, what's not so important, and particularly if the wife or the important other is with a patient in clinic, it can help me get a good insight into how that arthritis is affecting that individual. And it's amazing how much you can glean from someone within the space of 20 minutes. So honestly, I couldn't say there's one typical person who obviously needs a hip replacement. It's much more important to see how it affects that individual person's life. But certainly if you've got severe pain that's stopping you enjoy your activities of daily living, so you struggle to get out of bed in the morning, you can't put your clothes on easily, you can't walk up and down stairs because of pain, and you can't go out to enjoy shopping and enjoying friends and family, then clearly you're going to need a hip replacement. But everyone is slightly different. I mean, my father, for instance, he had an arthritic hip. He just used to enjoy playing a lot of duplicate bridge. And for him, as long as he could walk between the tables and everyone knew he couldn't go up and down stairs, and so they always made sure wherever he played bridge, there was a lift to use, he was happy. So he didn't bother with a hip replacement. But other people, they want to go walking for 3 hours with their dog each day. And if they can only walk for 1 hour, that's not good enough. And so we will do a hip replacement for them. So everyone is different. Some people get a lot of pain at nighttime. And if you can't get a good night's sleep, then you'll feel exhausted the rest of the day. You'll be grumpy with everyone and life is hardly worth living. So we need to do a hip replacement for those patients. Hip deformity, if you get stiffness in the hip, then that puts an awful lot of load on the back and on the knee. And in fact, to alleviate that back and knee trouble, you have to make sure you have a supple hip again. And if physiotherapy fails to give you the suppleness in the hip, then my goodness, you need a hip replacement. So on we go. So what are the types of hip replacement? People do ask me, are you going to do Andy Murray's resurfacing? And I'll say, no, we're not, because it does lead to a few insoluble problems in the selection of patients, and we prefer to avoid it because we have tried and tested solutions that provide you with a 20-year solution that'll give you a great result. If you're going to do a hip replacement on a 20-year-old who wants to achieve world-class athletic pursuits, then okay, you have to discuss slightly different solutions. But for the majority of people who are over the age of 50, a traditional hip replacement gives you a lovely result. But people do ask, well, what about the materials? What should I have? Should it be metal, plastic, ceramic? Should it be cemented or uncemented? Well, if you are an engineer, you want a bearing surface that leads to the least amount of debris and lasts the longest possible time. And we've done a lot of work where we have jigs, where you have bearing couples inside bovine serum, and you go through millions and millions of cycles of joint loading. And you discover how well these joints will actually do over 5, 10, 20, or even 30 years of use. And what we find is the best couple from the point of view of debris is ceramic on ceramic. It's a very hard surface and it provides very little debris. However, occasionally ceramic, which is a very hard, brittle structure, can fragment. And if it fragments, it creates a very difficult problem to solve because the ceramic debris is an irritant to the surrounding soft tissues, and it's very difficult to get rid of that irritant when you have to do the revision hip surgery. So it's something that you carefully select and choose the right patient for ceramic. Probably a safer bearing couple, and recently in the Hip Society, there was a show of hands from the members of the audience who are all orthopedic surgeons, and it was suggested, what would you like if you were going to have a hip replacement? And the couple that most of them went for was what's called hard on soft, which is ceramic on polyethylene. That is a more forgiving couple, doesn't tend to lead to the ceramic debris that you get from ceramic on ceramic, and it's probably going to lead to probably the potential of 20 to 30 years of good use before you get unacceptable debris being produced at the bearing site. Metal on plastic is the most established couple that we have, and we tend to go for that if you want the safest possible hip replacement in people that in general are aged in their 70s plus. because we know it is going to last for 20 years. Ceramic on poly, we are probably looking at 30 years life. But this is all theoretical, because what really matters is the interface of the component with the bone, because that's where a hip replacement fails. You get loosening of that interface. The reason you get loosening is because there's a slight mismatch in the stiffness of any form of metal component and bone, which is a biological structure that's changing its density and its stiffness with the aging process. And when you get a big mismatch, you can get loosening. But the debris from the bearing surface can also contribute to this loosening. So really, when it comes down to it, rely on the surgeon's preference as to what is going to be the bearing couple, because there is very little difference between the couples we use nowadays. They're all pretty good. And whether you use cement or uncement, again, is down to surgeon's preference, really, whichever fits well with their technique of hip replacement surgery. If you go into the National Joint Registry, it will give you some fine nuances and differences between them. But honestly, they're all pretty good. So on we go. Short stem. Well, remember I was talking about loosening of components and breakdown of the bond between the metal and the bone. Well, if you have a shorter component, it will then lead to an easier revision. But we won't mention any more about that. So what is involved during a hip replacement? The operation normally takes about an hour, and we like to do it under a spinal anesthetic, but that'll be discussed with your anaesthetist. And nowadays, you're just in hospital, probably for one night, maybe 2 nights. And the scar, yeah, that's a sort of fairly standard length scar. And it looks a bit pink there. That's because that's a fairly immature one. As the months go by, it becomes a very light color and you barely see it. So what is involved during the surgery? It is disgracefully straightforward, really. It's a matter of getting good access to the hip. And we do that by dividing a small number of muscles in and around the hip to make sure we get good access. Those muscles that are divided will take at least 3 months to recover from the surgery. And that's why the hip will feel a bit sore and a bit weak during that time. And we will resurface the socket and we will put a new stem onto the femur. And here's pictures of hip replacements afterwards. These are the x-rays. The x-rays on the left show a cemented component. You can see the cement around the femoral canal. On the right-hand side, that's a fully uncemented. They both give equally good results, those components. So the recovery from hip replacement, your hospital stay, we want to get you up and walking as soon as possible after the surgery, because we know that gives you the best possible result and the least amount of pain after the surgery. And your physio and nurses on the ward will help you to get up, usually on the same day as the surgery if it's been in the morning. If it's an afternoon then it may well be the following day when you get up. And the physiotherapist will instruct you in your exercises that you're going to do religiously when you get home. And normally you find you are back to activities of daily living within 6 weeks of the surgery. And usually at that stage, you're walking with one or no stick at all. And once you go home, we are going to make sure that you're going to be safe at home. So we'll know you'll be able to get from bed to chair yourself, and you should be able to get yourself to the bathroom and back without needing any assistance from anyone. And I like you to go up and down stairs. It's always a bit of a nonsense, patients to say, oh, you know, should I have my bed moved downstairs so I'm next to the loo? No, I want you to have that exercise of being enforced to go up and downstairs each day to build up the strength in your hip and get better. So after leaving hospital, certainly during the first 2 weeks, you'll need a lot of painkillers and things are going to be bruised and you're going to feel quite sorry for yourself, but you'll be doing all your exercises. And by about the end of 2 to 3 weeks, you'll think, yes, things are beginning to improve. And at 6 weeks, we would hope that you're walking outside your home and you're considering getting back to driving. And by 3 months, you'll be feeling pretty good. But the maximum recovery from hip replacement is probably about sort of 9 months to a year, actually, for the full recovery. So life after hip replacement, most patients get a great reduction in pain. It allows you to get back to your normal activities. Active sports, heavy labor, no, but you'll be back playing tennis. You can get back to some gentle skiing. You can do loads of stuff, and essentially you'll have a normal joint. But high impact activities like doing a lot of road running, not so good. We prefer swimming and cycling, which is a low impact activity for keeping yourself nice and fit. The precautions, a hip replacement is almost as good as a normal hip, but you don't want to go crazy with your yoga exercises, because don't push it right to the limit, because it's not quite as stable as a normal hip. So these are your rules. Don't bend more than 90 degrees. Don't cross your operated leg, and try not to twist it into contorted positions, just to try to look after your hip. Potential risks, we always have to discuss the risks of surgery, and we'll remind you about that when we see you in clinic, and we'll also sign a consent form that you understand it. The vast majority of patients do extremely well, but some do not do so well. First risk is thrombosis. That's where you get a blood clot in the legs. That's bad because these blood clots can go up to the lungs. It blocks them, stops them working, and I'm afraid that kills you. Risk of that, 1 in 1,000. Loosening of the joint. They don't last forever. We always tell patients we'd expect it to last for 20 years, but that's just the average. Some of them can only last 12 or 13 years. Some keep going for a lot longer. They can dislocate. Remember, we've had to divide a few muscles to get into the hip joint to start with. That leaves the hip quite vulnerable to dislocation in the first 2 to 3 months. And if it does dislocate, normally we can just put it back under sedation and get you going again, and it recovers nicely. Very occasionally, when it dislocates, the joint is loosened and we have to revise the whole operation. Leg length, we try our very best to get the leg length right, and we do a lot of preparation beforehand to do that. But sometimes it's necessary to change the leg length to ensure we have a nice stable hip during the surgery. Most patients will adapt to that. Sometimes they find it a bit of a nuisance and we might need a shoe raise, but that is fairly rare. Infection, that is the worst possible complication. There is about a 1% risk of that. And if you were to get a deep infection after hip replacement, that is a complete, total disaster. It means we've probably got to take the hip joint out, we wash and clean the cavity, we give you strong antibiotics, we put a temporary cement spacer in the hip, and that stays in for a month or 2, and we make sure the infection goes completely, and then we put in another hip replacement. But I wouldn't wish that on anyone. And as surgeons, we forget our successes, but whenever you get an infected hip, that patient, you remember them for the rest of your professional career, because it is a downer for the patient and also for the surgeon. It's horrid. So it's fortunately only 1. And I can quietly say that here at Benenden, our infection risk is lower than that, because we do have a very clean, very privileged environment we work in here. Damage to nerves and blood vessels. Yes, the sciatic nerve is very close to the operation site. You can get occasional stretching and bruising of the nerves, which can lead to temporary numbness and weakness. Occasionally, it is permanent. Sometimes the bone can crack around the hip replacement, and that can delay recovery. And sometimes we even need to sort of fix it with screws and plates. So there are risks, but they are rare. And finally, patient decision support tools. The National Joint Registry provides information on all surgeons that provide hip replacement in the United Kingdom, and is a great resource for giving you other links to give you information about hip replacement surgery. And I think that is me finished. Here's the summary. It's a highly regarded operation. It gives effective pain relief in the majority of patients. And it's not just for older people. You know, hip replacement is for anyone who has disabling pain. The youngest hip replacement I've done is on a 28-year-old physiotherapist who had a nasty road traffic accident when she was in her teens. And she was 28, but we had to do it there and then, and she got a lovely result. And it can give you your life back. Question and answers, please.
So thank you for your presentation. That was very interesting indeed. So now we'll now take some questions. We've got a few that have come in. So first of all, we have a lady who has said that she's in her late 50s and she's got to the point that she needs a hip replacement. When would she need revision surgery?
Okay, so this is very simple. It doesn't matter the age. I'm not an ageist in any way. It just matters whether or not she has symptoms that's stopping her from enjoying life. If you are in your 50s, I would expect your hip replacement to last maybe 15 to 20 years. Then you would need a revision. And then that revision surgery that's going to be done when you're in your 70s will probably last another 10 to 15 years after that. So that takes you from your 70s to your late 80s. And by that stage, you might think, actually, I'm happy. I'll put up with this hip that's a little bit achy and a little bit worn out. So my view is, if you aren't enjoying life because you're arthritic, painful hip, you need it doing right away so you can get on and enjoy some of the best years of your life. Do not delay the surgery and have it done when you're in your late 60s and think, oh my goodness, I should have had this done 10 years ago. Life is too valuable by being in unnecessary pain.
Okay, second question is, someone has groin pain intermittently following THR 7 years ago. They have pain at rest sometimes, not always on the weight-bearing hip. They've had an X-ray. Do you recommend orthopaedic review or wait and watch?
So she's got groin pain after the total hip replacement and has had it for 7 years.
Seems so, yeah.
Okay. Now, this needs to be investigated. Ongoing groin pain could well be due to us having got the shell in a slightly wrong position. So it's sitting proud of the host socket, and then it's irritating the tissues around that hip. That's a common cause of groin pain. Another cause of groin pain is ongoing grumbling infection. And the final cause is just, unfortunately, some scarring around the hip that we are not very good at sorting out. But it needs to be investigated. And the way I investigate groin pain is with an MRI scan or a CT scan. If you do the MRI scan, you need to have it with something called MARS, which is metal artifact suppression sequences. So we still get a good signal, even though it's close to a metal hip. And we will see whether or not there is irritation of the soft tissues from the metal of the joint. If there is, then there is a role for steroid injection under X-ray control into that tendon, which will then try to alleviate the pain. If you can't find a cause for it, then usually I'm afraid to say it's something one has to live with, but it can be investigated. And if you know what the cause is, sometimes patients say, oh, at least I know what it is. I'd rather not have any further surgery or anything. I'll live with it. But by knowing the diagnosis, it makes it much easier to live with it.
Okay, thank you. Am I able to have a hip replacement on the same leg that I've had a knee replacement previously?
Definitely, you can certainly have a hip replacement on the same size you've had a knee replacement. Strangely enough, we often see patients who have both an arthritic hip and an arthritic knee. And I always tell patients to have the hip replacement done first, because a lot of pain that you can perceive in the knee is actually coming from the arthritic hip in the first place. So it's very commonplace to have arthritis in both the hip and the knee. And I think there's no reason why you shouldn't go ahead with a hip replacement. And one might also say that if you do have a hip replacement above an arthritic knee that's been replaced, if you can then make the hip more supple, then it actually can take a lot of the adverse loads off the knee. So if you have a knee replacement that's perhaps been causing you a bit of discomfort, if you do a hip replacement on the same side, some discomfort you might have perceived within that knee could also improve.
Okay, so next question is, post hip replacement, how do you know if the hip has become infected?
Yes, indeed. It can be very difficult to know. As with all things in medicine, we want to have a history and clinical examination first of all. The kind of things that demonstrate you've possibly got an infected hip are that you've got constant nagging pain 24 hours a day. You've particularly got pain that's throbbing in nature and wakes you at nighttime. It could well be you feel systemically unwell, you feel a little bit sick, a bit off your food, you feel tired most of the time. That can suggest infection. And then when it comes to clinical examination, you look at the hip and you can see the skin around it looks a little bit swollen, maybe a bit red, a bit warm. That suggests you may well have an infection. But do remember, a hip is a very deep joint, so often the overlying skin will look completely normal. So that might not give you any clues. But when you find someone who has symptoms of this chronic low-grade ache, you will then ask them very carefully, did the wound heal well after the hip replacement? Or did you have an oozy wound for a week or two? That can suggest you're perhaps more likely to have an infected joint. And then we also ask from the history, have you had any recent dental work done? Have you had any abscesses or wounds or infections elsewhere in the body that could then have spread to the hip? So those are the things we look for in the clinical history and the clinical examination. Then, of course, we would do blood tests. And there are two blood markers that show if there is generalized infection in the body. This is something called the ESR or the CRP, and the GP would take these two blood tests and see whether you have got elevated markers. If you have, again, we want to make sure you don't have infection elsewhere, because that would then give you raised markers. But if you actually haven't got infection elsewhere and you've got a painful hip and your ESR or your CRP is raised, then that suggests you've got infection. And once we seem to think you've got it, we would then x-ray you, and then we would probably aspirate the hip under x-ray control in sterile conditions in the theatre to get some clues as to whether or not there is infection growing in the hip. And then, of course, if there is a positive infection, then you'd be seen by one of our special multidisciplinary teams that will actually advise you about the various options that are available for you to overcome that infection.
Yeah, thank you. I hope that gave that patient peace of mind there.
Good.
So John says, how long following the initial consultation would the surgery take place?
Well, that does depend a little bit on the time of the year and the waiting lists and such like. I'm probably not the right one to ask because I haven't looked at that closely for the moment, but I think it's about 8 weeks, but don't quote me on that. But I think at the moment we're looking at an 8-week run-in to get hip replacement surgery here at Benenden.
Yeah, so you'd have a new hip in time for a new year potentially, if you would book your initial consultation now.
Yeah, well, I did say the time of the year. There's Christmas holidays coming up and such like. And so I think if you booked it right now to have it by the new year, that would be a real stretch.
Yeah.
I would say it would be done early in the new year if you book it right now.
Yeah. And what is the difference between a cemented and uncemented hip?
Yes, I do apologize. I sort of brushed over that fairly quickly because I looked at my watch and I was meant to speak to you for half an hour and we were at 42 minutes at that stage. So what is the difference? Well, it's an interesting one, this. Traditionally, we always used to do hip replacements using polymethyl methacrylate cement, which is a dental cement, because it was always felt that was the best way to bond the components to the bone. And this is John Charnley back in the 1950s and 60s. We then found that hips started failing and the bond between the components and the bone failed. And when it failed, you would get lots of cement debris being produced. And so we erroneously, mistakenly thought at the time that it was the degradation of the cement and the breaking down of the cement that caused the hips to fail. So as a result of that, we started devising other ways of fixing components. So we used an uncemented component that would rely on a press fit with special coatings on the stem that would allow for bony ingrowth into that stem. So that would be an uncemented component. There was no cement filling in, there was no grout effect of the cement, and we had this bony ingrowth. And we thought that would lead to better bonding. We've actually found that the way we've improved our surgery over the years and become more nuanced in our hip replacements, that actually uncemented is no better and no worse than cemented. So it's a mistake we made initially to think that cement was responsible for loosening, but that's what led to us developing uncemented components. So nowadays we have both components available, cemented and uncemented, and it is entirely down to surgeons' choice which one they prefer to go for. If you ask most surgeons honestly why they do uncemented, we would say, well, actually, it's a more refined operation. It's a little bit more technically challenging. It's nice to try to get a lovely fit with the uncemented components, and the operation is a little bit quicker. And most surgeons, we love doing things with our hands. We love being creative, and we like an operation that has a little bit more technical finesse to it. And obviously, if you can do it a little bit quicker, it allows you to operate on more patients in the day and get rid of these colossal NHS waiting lists that we have. So that's the other reason why we prefer to often do uncemented rather than cemented joints.
Okay. So just a couple more questions. Is pre-operative physio recommended?
Okay. So this is called prehab. This has become something that we've recognized is exquisitely important to get a great result from your surgery. So it always helps to exercise as much as you can before surgery, get yourself into a swim pool or onto a static bike, or see a physiotherapist who will also give you advice about how to get yourself as strong as possible for the surgery. Obviously, if you've got a nasty, painful, stiff hip, it's going to be very difficult to do all of this. But honestly, if you can manage to just build up your muscles a little bit, it will make the recovery all that bit quicker and easier for you. So yes, always do some prehab if it's not too painful. And don't think that resting the arthritic joint is the best thing to do for it. Honestly, it isn't. Try to work through the horrible achiness if you possibly can.
Okay. Final question is, what level of sedation is decided on when you have hip replacement surgery?
Okay. Now, very good question, this one. I've recently had 3 general anesthetics myself in the last 18 months. And I was asked, did I want to have a spinal or an epidural? I'm afraid to say I didn't want to know what the surgery was because it was all orthopedically related. So I wanted to be in blissful ignorance. That was my decision, but actually that probably wasn't the wisest decision, because if you ask most anaesthetists if they were going to have a hip replacement, would they have a spinal with sedation or would they have a general? They would normally say a spinal with sedation because it's safer. It's quicker to recover from it. You'll have less nausea, less pain. It's the best solution. But the thing that worries patients, they say, oh, I don't want to be aware of the operation. I don't want to hear all this sort of banging and sort of use of chisels and things. I want to be blissfully unaware of it. Well, in fact, that's how we gauge the amount of sedation we give you. If a patient really doesn't want to be aware, we will give you a level of sedation so you're actually sleeping nicely during most of the operation. We always say most because there's always a slight chance that you might have slight recollection of various aspects of the operation, but it will not be unpleasant. It will be just as though you're in a lovely little dreamy sleep. So the answer is to sedation. We give you enough to make it an enjoyable, pleasurable experience. And the patient will discuss with the anaesthetist exactly how much awareness you want during the surgery.
Thank you. Thank you for all those answers. I'm sorry if we didn't manage to answer all your questions. If you've provided your name, we will answer yours via email after the webinar. So, Ms. Dunnet, could we just move on to the last slide?
Of course.
Lovely. So, as a thank you for joining this session, we have an exclusive attendee offer. So you can get 50% off your initial consultation. You can have a call back from your dedicated private patient advisor. An email will go into your inbox tomorrow with a recording of the session and any further information as well. And you'll also receive exclusive updates on news and any upcoming future events that we have. So if you'd like to discuss or book your consultation, our private patients team can take your call until 8 p.m. tonight, or between 8 a.m. and 6 p.m. Monday to Friday, using the number on the screen. We'd be grateful if you could complete the survey when this session closes to improve our future events. Our next webinar is on varicose vein treatment, which you can also sign up to via our website. So on behalf of Mr. Dunnet and our expert team at Benenden Hospital, I'd like to say a big thank you for joining us today. We hope to hear from you very soon. Thank you. Goodbye.
Bye-bye.